In today's lecture, we're going to talk about respiratory failure and airway adjuncts. So, um, with a patient with respiratory failure, initially you will start typically in your algorithm with O2. However, if they continue to fail, you'll switch to CPAP and or BiPAP. CPAP is for patients with a poor oxygenation status, those patients with pulmonary edema, pneumonia, trouble with oxygenation. This is because it provides a PEEP or an expiratory pressure to the patient, which assists in oxygenation. If you have a patient with ventilatory failure, meaning they are hypercapnic, or they are having trouble taking adequate deep breaths, you would switch to BiPAP. BiPAP itself has two levels. It's a bi-level pressure, so it has an EPAP and an IPAP. For more details on this, you can see our previous video. However, our BiPAP system has a toggle switch on it, and it is completely dependent on the flow of oxygen, on what pressures you're generating through that BiPAP mask. If a patient continues to fail and has a decreased respiratory drive, you can switch to bag valve mask ventilations. If you are having trouble ventilating the patient and maintaining adequate oxygen saturations, you would switch to a bag valve mask with a PEEP valve. Typically, BiPAP provides you an EPAP. This is the same function as our PEEP valve. To maintain an adequate EPAP, you're going to need to maintain a good seal, or you will lose the end expiratory pressure on that patient, and you will drop to a functional zero. The pop-off valve on the bag valve mask will provide you about 3 to 5 millimeters of water. Anything above that is needed to oxygenate the patient, you will need a PEEP valve. For the bag valve mask, as long as you are getting adequate compliance during bag valve mask ventilations in a single or double rescuer situation, you do not need to place a advanced airway such as a biad or intubating the patient. However, depending on their mental status, they may need an airway compromise, including aspiration, vomitus, airway injury. All of those are reasons to consider placing an airway. When we move to placing an airway, there's a couple options that we have. You have OPAs and NPAs. OPAs can be placed in a patient without a gag reflex. Typically, you want to make sure that the tongue is out of the way in whatever method you're going to use to place your OPA. Be careful with this one, as it can lead to a gag reflex and emesis and ultimate aspiration. NPAs are typically a little bit safer. Those will go through the nasopharynx. They can assist in keeping an airway patent for bag valve mask ventilations. You do not necessarily have to proceed down this step as long as you're getting adequate compliance with the bag valve mask. However, it is a good adjunct to make sure that your bag valve mask is working appropriately. Often we next move to biad. However, intubation is always an option. From the intubation perspective, there's a couple things to consider. You want to look at your blade choice. So typically an adult female is a Mach 3 blade. Typically an adult male is a Mach 4. However, this depends on your experience and what you like to use. You can also use a Miller 3 or a Miller 4 for those patients. There's always video laryngoscopy, that's an option, whether that be GlideScope, King Airway, or King Vision, whatever your current video laryngoscopy method of choice is for your department, or for our department. Once you get to the situation of intubation, your tube choice is also very important. So 7.5 typically for females and 8 for males. Obviously, the larger the size, the better ventilatory status you're going to maintain. The larger the tube, the higher volumes you can get into the patient, and it aids us in the hospital. So try to pick the largest tube possible for that patient. Females, typically once you intubate, the depth is about 21 to 23 centimeters, and for males it's about 22 to 25 centimeters depending on their height for depth. For the actual method of direct laryngoscopy, there's many ways to do it. There's different adjuncts, there's bougies, there's stylets. There is multiple different types of tubes, but typically RET tube will require a stylet and or a bougie for placement. When you're going to intubate a patient, position is definitely key. So you want the tragus or the earlobe at the level of the sternum for the patient. So typically that is a sniffing position for the patient. So you want their head forward. When you insert the blade into the mouth, if you're using a Mac blade, the tongue sweep is very important. This will primarily be a discussion about Mac blades. You will enter from the right side of the patient's mouth. When your blade touches the uvula of the patient, that is when you start your lift. That will allow you to place your blade directly into the vallecula in front of the epiglottis and obtain your view. Your lift from that standpoint is to the corner of the room, or the 11 o'clock position, so kind of upward and leftward. If you do not have a view at that point, you are either in the esophagus or you are too shallow. So the first step of any laryngoscopy is valleculoscopy. So you want to see the vallecula or you want to see the epiglottis. If you are seeing pink, just pink, and you can't tell where you're at, you can always back out to try to locate the epiglottis. There is a very intelligent doctor named Dr. Kovacs who came up with a method of difficult airways and attempting to figure out how we are going to navigate that, and he calls his system the Kovacs kata. If you do not see the airway, the very first step is to put your hand on their cricothyroid membrane and provide cricoid pressure. That is always the first step, because then you can manipulate their larynx into your view. If you can't see anything at that point, you can always take your hand and put it on their occiput and you can lift their head, and that will give you that sniffing position or ramped position. You can move their head in multiple different directions from that standpoint while the blade is in the mouth and you're attempting to view the vocal cords and the arytenoids. If you do get a good view at that point, your assistant can hold the head in that position so that you can pass the tube. If you do not have the strength to lift their head, typically with a laryngoscope blade, you're supposed to lift their head off the bed or the floor or wherever you're intubating with some force to allow the vallecular ligament to release. If you do not have the strength to do that, you can use both hands to lift, and that can often provide your view. The third step is, if all you see is vallecula, you can use your Mac blade like a Miller blade and scoop their epiglottis. That will allow you a better view of the cords fairly often. And then the last step is to pull back, and that is typically for video laryngoscopy. Typically you want your view of the vocal cords in the upper third of the screen. If you are unable to pass a tube at that point, biad is always an option. We use the King Airways currently, looking at using the AirQ3s, which are laryngeomask airway. Both of those you insert blindly past the tongue, make sure the tongue is not in the way, and seat it between the two lines demarcated on the device, and provide bag valve mask ventilations. Obviously, once an airway is placed, you want to confirm with capnography, oxygenation, and auscultation to make sure that you are not getting any bowel sounds out of the bags, the ventilatory effort. And that will be all for today. Thank you.